Our final Pursuit Award nominee is Dr. Karen Hurtubise. Karen completed her doctoral studies in health science research at the University of Sherbrooke. She's currently a postdoctoral fellow at the School of Rehab at the University of Sherbrooke with a focus on parent coaching approaches to pediatric rehab in telehealth. Her clinical research has aimed to better understand the experiences of children, youth, and caregivers with the healthcare system and apply patients and public engagement strategies in co-designing, implementing, and evaluating novel interdisciplinary rehab models to improve service access. She's also leveraging her doctoral study findings in assisting the co-creation of a provincial chronic pain step service for children, youth, and their families in Newfoundland and Labrador. Wow, covered a lot of ground in one doctoral thesis. So please welcome Karen.
Good morning, and thank you for the opportunity to present at the Holland Bloorview Research Institute Pursuit Awards. My name is Karen Hurtubise, and I'm a postdoctoral fellow at the University of Sherbrooke. It gives me great pleasure today to share with you some of the findings of my doctoral dissertation. So what if I told you that 1 in 5 of our children has recurrent or persistent pain lasting more than 3 months? Chronic pain in the pediatric population is increasing at alarming rates, a public health emergency that needs to be recognized. If left untreated, pain can cause damage to the body and brains of our children. Pain affects all areas of development. It can create serious limitations in a child's physical functioning, their ability to attend school, and interact with other children. In essence, pain stops kids from being kids. And what if I told you that these consequences extend far beyond the child themselves into their families, our communities, and society? Pediatric chronic pain costs us 16 billion Canadian dollars annually. That's more than childhood obesity and asthma combined. And sadly, the consequences impact family functioning and can result in long-term impacts on the sibling and parent mental health. If left unsupported, kids with pain-related disabilities become adults with pain-related disabilities. In fact, statistics show that 2/3 of these children will become adults with chronic pain. And what if I told you that we don't even know what treatment is most effective? What we do know is that medications alone are not the cure. Multidisciplinary rehabilitation treatments are what is being recommended. 2 models exist. The intensive interdisciplinary pain treatment, which although rare in Canada, can be found on some inpatient units, day hospitals, or a combination of both, and the more frequently encountered multimodal outpatient treatment model. However, neither of these have been proven. Program variations have precluded the clear study of their effectiveness and their comparative effectiveness. We have also failed to identify when we should treat these children, who should treat these children, how much and how we should treat these children, where we should treat them. Furthermore, although some treatments have been evaluated, the outcomes have focused on what clinicians and researchers believe are indicators of success. Evaluation research espouses a judgment on value. Sadly, the evaluation of pediatric chronic pain interventions to date has failed to capture the perception of those that receive the treatment. Youth with pain-related disabilities and their parents' voices are absent from this literature. My doctoral study attempted and was able to fill some of these gaps using a participatory evaluation approach and some novel and innovative research methodologies. Here's what we learned. By partnering with youth with pain-related disabilities and their parents, clinicians and physicians that treat them, as well as healthcare administrators, we were able to prioritize 6 outcome domains upon which the evaluation of our multidisciplinary rehabilitation treatments at our facilities would be based. The 6 domains are illustrated here on this slide. Unfortunately, we quickly realized that patient-reported outcomes were only available for 4 of these domains, leaving 2 unmeasurable. This identifies an important measurement gap. Using the available measures, we evaluated the 2 service delivery models available at our facility. Our multimodal outpatient treatment, which is comprised of at least the 3 disciplines identified here on this slide, as well as our more integrated model, that of our intensive day hospital program. What we learned was that our intensive day hospital program was effective both in the short term and in the long term in reducing the interference pain had on youth's ability to perform their activities of daily living. It also proved effective in decreasing, in the short term, depressive symptoms. However, unfortunately, the benefits were not seen long term. Surprisingly, we also learned that youth participating in our multimodal outpatient treatment tended to report better quality of life at 12 months than those in the intensive program. When interviewed, the participants in our intensive program told us that they had had difficulty transitioning back to real life following the program, resuming peer relationships and friendships, keeping up with schoolwork and school expectations, in particular with graduation looming, learning to self-manage in their new reality, as well as identifying meaningful activities, were all challenges that they faced post-program. This raises important questions around where we should treat these children. Should we remove them from their context or meet them there? It also raises important considerations with regards to when we should treat these children. Are there population characteristics associated with age and academic trajectory which match better with one service delivery model as compared to the other? And finally, youth with pain-related disabilities and their families also highlighted to us the program components they most valued. These included pain education and learning about pain strategies, peer support for both children and their parents, as well as coaching in context, in the context of their pain, in the context of their family, in the context of their real life. These 3 components transcend disciplines, which raises important questions about who should treat these children. So where do we go from here? Well, these findings are important to consider when recommending treatment to youth with pain-related disabilities and their families, as well as in developing future programming for this population. However, there are also other key messages that I feel compelled to share with you today. First, youth with pain-related disabilities feel invisible. Invisible in their care, invisible in research, invisible in society. Youth that avail of our services tend to be Caucasian, English speaking, from high socioeconomic status, with married and well-educated parents, and who very rarely have other varying abilities or medical diagnoses. We need to question equity. We also identified an important measurement gap. Instruments to measure what is most important to youth with pain-related disabilities and their parents do not exist. Can we truly establish evidence-based effectiveness without these measures? The services that we provide are located in health facilities that are specialized, typically in urban centers, away from the lives of youth with pain-related disabilities and their families. Is this appropriate access? And finally, we have been led to believe that more treatment is better, regardless of system costs or costs to the family. Is this being accountable? Pain is the most common symptom that brings parents to seek medical attention and advice for their child. Chronic pain is undoubtedly complex and is most certainly a family issue. For youth with pain-related disabilities and their families to have access to compassionate, equitable, evidence-based, and cost-effective services that allow them to enjoy a meaningful and healthy life, courage, resilience, and innovation will be required on our part, on the part of the research and clinical community. The research and practice silos that currently exist, such as those in the fields of childhood disability, childhood pain, as well as pediatric and adult services, need to be broken down. Clinicians and researchers need to commit to partner with youth with pain-related disabilities and their families to identify their needs, ways to measure what is most important to them, to co-create acceptable, feasible, and efficient services, to locate these services where the families can access them when they need them. We need to do better for Canadian children and their families. Thank you. I'd like to acknowledge my thesis supervisors, the leadership team at Alberta Children's Hospital, my lab colleagues, the funding agencies and training programs that supported me during my doctoral studies, the wonderful members of my advisory committee whose wisdom and stewardship helped me bring this project to completion, and most of all, to the participants of this study, the parents and youth who so willingly shared their experiences and allowed me to walk alongside them for part of their journey.